Hi, everybody. This is Seth Keller. I greatly appreciate everyone coming on. This is now part two, as been described, on this topic of COVID-19 in people with IDD. I'm going to be focusing mainly on the issues relevant to people with IDD, but also in particular when they age and have dementia. And I'll be speaking about the cross section between aging and dementia and how these two will be relevant. So hopefully this will be of interest to you. And again, I appreciate greatly for everyone coming on to the presentation. Thank you very much. I have nothing to disclose, no financial arrangements or conflicts of interest, so wanted to just get that out of the way. And one thing that I know that much of us who've been living with this situation, pandemic of COVID-19, have heard a lot already about how things have gone awry in certain populations of people, more so than others with COVID-19. And the two main things I want to focus on this slide are in particular those that have pre-existing conditions, as well as what's relevant to the age of the individuals. And as you can see by these two graphs, the one to the left talks about the death rate in particular for those that have pre-existing conditions who are hit harder by the COVID-19 virus. Heart disease, diabetes, respiratory issues, immune deficiency issues are very relevant. And also the to the far right graph are those that are older populations and those that are over 65. And then on top that, when they have the pre-existing conditions, it's a combination of lethality, which is very troublesome and worrisome for these very vulnerable populations in that respect. So that's something very concerning. But what is it about people with dementia and COVID-19 in particular that make them vulnerable in that way? And dementia, just by and large, are those who have progressive decline in their cognitive abilities. And in general terms, for the general population, it's mostly over age 65. However, there is early onset Alzheimer's disease, which I'm going to be speaking much about in the next slides ahead, in particular those with Down syndrome. The difficulties inherent in people with dementia are issues that are very relevant to COVID-19 that we all think about, is understanding about what we're hearing about now about hygiene, social distancing. So in people with dementia, they may have difficulties in appreciating instructions and following them, and therefore might be placed at a higher risk of getting the virus. The other part that's also very relevant to dementia is where people live. Congregate living, in particular, for those that are living in assisted living or are living in long-term care facilities, they are at higher risk of also getting the virus because of the fact that they're around and in close proximity to others. Those that have dementia also, as they progress through their disease, have issues related to problems increasing with respiratory difficulties, swallowing difficulties, and states at which they are more compromised overall for picking up viruses and other things that could hit them and hurt them harder. And the relevant issue also to dementia is the associated difficulties related to the caregivers themselves, the challenges that they have that are very relevant to people who are dealing with stress, the availability of also protection of equipment, and the like. So that's very relevant to those that are getting support around them and are hit hard. What about people with intellectual and developmental disabilities and Down syndrome and COVID-19 in particular? First of all, the question of what do we really know about the data? And there was reports that come out, and I'm going to focus just to that graph on the far right, high above, that has a graphic representation from a study a few years ago for people that had pneumonia or other illnesses in those with developmental disabilities, Down syndrome, and non-developmental disabilities and pneumonia. And it's there in prior studies showing that people with intellectual disabilities, Down syndrome who actually have shown to have higher propensities to get sick and have complications from illnesses like viruses. So there is a history behind that. And because the current COVID-19 pandemic has only been upon us for several months, we don't have enough yet, all the statistics. However, we do know, and this is now going back to all the bullet points, people with intellectual disabilities, Down syndrome, may have higher risk of breathing difficulties, swallowing difficulties. They might have higher risk of having history of lung difficulties. People with Down syndrome have higher chances of having sleep apnea, obesity, cardiac problems. Their immune system may be altered, and higher degrees of chronic disease, including behavioral difficulties in general population with IDD is certainly very relevant and prominent, as we all know, who care for this population. People with autism inherently might have social difficulties and how they are impacted upon people, or rather with the virus itself, about being quarantined, social isolation, following suggestions or recommendation for social distancing, or even wearing a mask may be very challenging. People with developmental disabilities often might be treated for various problems of their health, epilepsy, blood pressure issues, diabetes, thyroid dysfunction. And when you add much of these up, that is a predominance of multiple medications, which into itself might be relevant to making their immune system or body system more compromised and perhaps set them up. This is somewhat more theoretical than factual. Congregate living, I underline that, or rather I boldface that, because I think that is something that I wanted to make sure that this is a clear reality for a number of people who are certainly older population living in group homes or other facilities. And as we certainly know, congregate living is a high risk for getting the virus, COVID-19. And the associated issues of ability to follow and maintain adequate hygiene guidelines also could be problematic as well. And then also the impact associated with caregiver concerns and issues, so much just like I just mentioned previously on the previous slide on dementia, is very salient to this. And then finally, I do say that the data is really not there, but we do have concerns that this might be the case. What I wanted to do in the next number of slides is to go through different timelines of how COVID-19 may be affecting people with intellectual disabilities and dementia, and how each of these certain situations are very relevant. I'm going to focus on them. The issues of social distancing, isolation, getting sick, going to the hospital, and the recovery. I'm going to spend a little time focusing on each of these and delve into that in some respect. First of all, what happens in situations with social distancing and isolation? Well, we know by and large, because we're all living with this situation ourselves, is our routine is absolutely different, absolutely changed. And I'm showing some really beautiful pictures that have been passed on to me of individuals who I've spoken to, who've really been explaining their own life situations, how they've been affected in their lives. And I wanted to, give them credit for their own isolation and stories that have been passed on to me in some respect, with both Kathy and by Scott, who are individuals who are living with Down syndrome and dementia and have been affected by their own way. So how they've been affected has been shown to me or talked to me about how they're out of their norm and routine, and the restrictions put into them are very concerning to them, and they're being put into certain rounds of life that are very different. So they're being scared of the situation, not following the types of situations that they used to be before, or don't really understand, well, why can't I go out? Why can't I go to my program? Why can't I be around other people? And even the thought of saying that you're going to go out there and people might make you sick might not be fully understood. What does that mean to me? Am I now going to be fearful of other people when that really shouldn't be fully the case? So the instructions alone are very challenging for that. So this will be very interesting when we talk about not only the current situation with social distancing, but how will this evolve once we begin to hopefully open up in the future, to learn and know that we should lessen up being less afraid or less fearful. So these are things that we'll have to see on levels of anxiety or apprehension that might stick with people as we begin to open up. And what do we say? What do we do? How do we handle it? But the one thing also is very relevant to think about is that as we're all now sitting in the crisis mode of the pandemic, we're right now dealing with the immediacy of the worry about the virus, worry about getting sick. And in many people that have intellectual disabilities, they have underlying chronic conditions. And are those chronic conditions, health issues, being kept on top of? Are there medical components being really addressed continually all the time? So these chronic conditions that they've had with them, behavioral difficulties, thyroid dysfunction, blood pressure issues, diabetes, anything at all, seizures, you name it, their dementia in respect as well, they're not going away. But are they being maintained? Are they being addressed? And are these issues now continually be talked to by their primary doctors or specialists? And I say this in somewhat of a rhetorical way because it's really not clear, because some of the office visits, as everyone knows right now, are being cut back or being postponed or being maybe held to telehealth visits, and they may not be dealing with some of these chronic issues, but they really need to be thinking about them. Are the issues of the caregivers being looked at as well? So caregiver support is such an important thing to maintain the ability of the family member, the caregiver, throughout this time of isolation and quarantine ourselves. And I did mention telehealth as an avenue that has to be looked at continually now, and where will this go also once the virus lets up? The issue that we all know, and we're doing this ourselves, is staying connected. Are we able to maintain the same kind of relationships that we had with family, friends, colleagues, others that we really should have stayed before when we're open there without the virus? Are these same situations still currently being looked at? How do we do it? Are we using Zoom? Are we using FaceTime? Are we using the phone call to ensure that these connections are done? What about just staying healthy? The gyms are now closed. Special Olympics is probably cut back. I know they have throughout the country about having programs and games and organized types of activities. What about wellness and health promotion? The important things of eating right, mentally staying happy, the ability to get exercise. Are these all being done? And they need to be. So what type of activities are being done by the families and organizations that people are being supported? It's hugely important for not only, of course, IDD people and their family supports, but really all of us, of course. What about the dreaded illness? Well, right now, as we hear all the time about people getting sick and dying from COVID-19, we know that we're always having a watchful eye of all the signs of the illness. Are fever checks being done? Some of the more unusual difficulties that we hear about with COVID-19 are there stomach issues or gastrointestinal difficulties, respiratory complaints. And certainly, as we know, in people with IDD and in particular with dementia, their ability to perhaps communicate or relate some of these difficulties themselves may not be as open as just, say you or I had illness that we'd be able to know, oh, I have a fever, I feel short of breath. They may not be well. Are the care practices being put in place, and how are they being put in place when someone is getting sick, or the personnel around them, the family members, are they putting into quarantine? So if they're living in a group home, what is the group home doing to isolate or quarantine the person who may be sick? We hear much that people that are might be having COVID-19, are they even being tested? And right now we're dealing with the question of, is there access for COVID-19 testing? Are we having people go to urgent care? Are we having people run to the emergency room? If someone gets sick, do they call the primary doctor? What would their primary doctor say? Right now we hear a lot of information that people really should be avoiding, perhaps going to the emergency room, unless they are really feeling somewhat more of the prominent difficulties, and they should really only hold off on doing that. What is the personal protection equipment, or PPE, that people are using to protect themselves in their group home or family situation? What masking do they have? Are they using a surgical mask? Are they using a bandana? Do they have the more higher level of the N95 equipment? And when do people really decide about when they really should say, okay, now I'm becoming more concerned about my illness, and therefore I need to now consider going to the emergency room. Otherwise, if they wait too long, by the time they seek emergent care, their illness or underlying breathing or respiratory difficulty or fever, they become so problematic by the time they decide to go to the emergency room, it might be too late and they're too sick. What are the issues of getting sick, being sick, and the stress that puts upon the person who's sick, the roommates who are there around them, and the staff themselves? What is the stress and how do we alleviate those worries, concerns? I say it in a rhetorical way because I'm really focusing on these are very important issues that really are talked about. Fortunately, because we are a group of organizations that care a lot about developmental disabilities, we have been having a number of information that is being passed out. And on this particular slide, I'm showing information that has been shown of flyers. The one to the far left is COVID-19 information by and for people with disabilities. So they have language and information that they can read. We have a number of webinars, and I'm just showing you one in particular that our friend and colleague Rick Rader has done in participation with the National Alliance of Direct Support Professionals, where he specifically is giving guidance to those direct support professionals in the world of COVID-19. And he's done up to 3, and I believe he's doing another one soon. And the far right is graphic information about a question answer that the National Task Group, in partnership with a number of other organizations, have worked together to put questions and answers were relevant to Down syndrome and COVID-19. And I have the links there. Both are available information on English and Spanish. So these are resources that have been very prominently known, and they're going to be updated as well. What happens when, unfortunately, the illness of COVID-19 or suspected illness gets bad enough? People go to the hospital, as we know. We're hearing about it every day in the news about people going to the hospital. We hear every day, especially in those cities like New York City. I live and work in New Jersey, and New Jersey is an epic center of a hotbed of COVID-19 like other cities. What is the testing being done? What's the right test that's being done to positively show COVID-19? What is the various treatments that are being done for people? And as we know, when people go to the hospital, the first step is always a triaging, the ability for them to be first seen in the emergency department. And the emergency department is the first line after they go through perhaps even first responders, 911. The paramedics take them, they assess them, they bring them to the hospital, or the caregivers bring them to the hospital. The evaluation in the emergency room. Are they getting the kind of care they need? And I'm going to come back to that in my conversation and discussion relevant to equity of care, relevance to are they getting equity toward because they have a developmental disability? Are they being treated as equals to other populations? Would they have the access to right medication, to treatment? I'm going to talk about that. In the hospitals, as we know, we're being quarantined. People with the virus or suspected the virus of COVID-19 are being isolated, and those family members, caregivers, are not, for the most part, being allowed to come to the hospital. And this is an issue that we in the National Task Group and the AEDMD are looking very strongly for advocacy work to try to raise the awareness that it is somewhat even unfair for people that have difficulty with communication, difficulties, social difficulties, people who have autism perhaps, or others who may not understand instructions, who are now seeing people that come to them in the hospital with these gowns and masks and faces that you don't even understand. It could be quite a scary situation for anyone. As the illness in the hospital is being treated, people can move from the emergency room, they move to the hospital bed, and if they're poor, and if their illness takes upon them in a very dramatic, poor way, they then move into the intensive care unit. They're put on medication, including sedatives and various treatments for the COVID virus, or to try to help fever or the respiratory difficulties, including even being on a ventilator. Sadly enough, of these illnesses takes hold on a lot of people and they might get through it, then the issue of palliative care, which is chronic disease management, is being introduced, but also the concern about their failures, about able to survive the virus and death and dying. It happens to so many people. And what happens when this issue comes up in the hospital, to the word, to the people supporting them, communicating them. How are we looking at that situation in terms of even understanding it and getting our minds wrapped around it? And even sadly enough and tragically, they're dying and going through the grieving process. We really are looking to find ways of improving care, do we not? And I did say that strongly. So one thing, since in many cases the family members or care support are not always able to be there, is the communication and data. Communication, accurate information. So there have been forms, and they're in the form of health passport, various summaries of written information about the individual, their likes, their personalities, their characters. They're written documents that in many cases can be downloaded and sent to the individual so that the people caring for them in the hospital would have more information. We care so much also for people who are caring for the direct supports and they're themselves. And the issue about providing the ability for the direct support professional to be able to allow them to come into the hospital has been provided through the national initiatives, through what's called the CARES Act provision through our government. And it does provide information in some respect to be able to provide funding for an organization, a community support organization, to be able to provide funding so they can send their individual support professional to be able to go to the hospital. But as I mentioned earlier, what are the hospital visitation? There are situations, I mentioned certain states are looking at this issue, including those through New York Department of Health, have just recently, in fact, it was just at the end of March, have been given the clearance to be able to provide people with cognitive dysfunction, dementia, intellectual disability, the ability to have a direct support or family member be with them. Right now in New Jersey, through Disability Rights New Jersey and the advocacy work through the ARC and others in my state, working hard for that. Same things are happening through Tennessee, but it's really much to provide the national advocacy effort to fight hard to show that this population, those that we're talking about and we all care for, are having the right to be able to have the word so they can get in and have the kind of care they need to ensure the equity of care is being provided, which is so important. But is equity care actually being done? Well, I wanted to give information, I imagine, for those like me who are in the field to appreciate that I'll use the term sounding an alarm. Here is one of her friends, Matthew, and I was able to meet his mother, Susan, through an article where it says here, I am ventilator worthy. And this is an article that came out through their state of Alabama, because there were certain states that were putting out guidelines on whether or not ventilators had to be rationed, and how would a hospital look at which population, what person, if they had to choose between one person or another person and they only had one ventilator or less than ventilators. So there were basically certain hospital systems in certain states were trying to come up with regulations. And in certain states, including Alabama and Washington State and others, they actually were trying to discriminate or try to look at situations where the people theoretically with intellectual disabilities may be on the bottom rung of getting this. So discrimination, it was very concerning that people coming to the hospital. So fortunately, through HHS and their Office of Civil Rights, they've been very much looking at these situations and tackling these issues one at a time. And that is to the far right on the HHS guidelines. So please, if you're able to later get my slides, link and get this information and find out as advocates we can do this. The one in the middle is also through the Center for Dignity and Healthcare for People with Disabilities, through the USAID and grant system that we're the ADMV is part of, as safeguarding against disability discrimination for COVID-19. Equity of care, knowing the best practice, how to take action. This is all information that we are looking at to ensure that this is something being done in a fair way. When people get into the hospital, again, going through testing and systematic evaluation, As we hear about this swabs and nasal swabs, there's a test that can be done through looking at saliva, blood, fecal material. The virus itself can live in many respects. We also look at what are called antibodies. The antibodies are those that are like our body's reaction to these viruses, where we build up antibodies, which doesn't happen right away. The graph, which I'm showing to the far right, shows earlier on when we get infections like any kind of virus, we build up what are called antigens and viral DNA in our body. That's what's seen first in any of our bodies when we get some type of infection, and that is actually what is shown up on these various tests that are being provided to check for COVID-19. However, after someone has an infection, these antibodies build up, and these are other tests that are being looked at later to show that you build up an immunity for these viruses, the antibody themselves. And there's different kinds of antibodies. But the reliability on some of these tests, which is another question, are they really 100% accurate? Are they really getting back the information that the person, do they really have it? Are there some irregularities on the test? Are they missing whether they really have it, or are they sometimes even falsely saying they have the virus when maybe they don't? How long does it take for the test result to get back after it's done? Does it take a minute? Does it take an hour? Initially, when all these tests were developed, sometimes they would take almost a week or longer. That's a horrible thing. Also, and plainly, what was decided on COVID-19 was just the symptoms of it. If you have a high fever, you have a cough, if you been excluded for other possible pathogens such as the influenza virus or other infections, CAT scan of the chest, X-ray of the chest, blood tests, or certain blood changes that also are highly indicative of COVID-19, including what is called CRP or reactive protein, ferritin, LDH, CPK. These are different aspects that are looked at in the blood to see if the virus has affected other body parts in the body system. The treatment is very different. We don't have a lot of great treatments. The first treatment was making sure it doesn't spread to other people. Fever, making sure that the temperature is reduced by providing information. And unfortunately, people are not always feeling so good about eating and having their fluids, so those types of treatments are often provided. Support for the respiratory status or heart status are being provided. And I use the next one, antiviral therapy, is what could be done to give the person to stop the virus so it doesn't spread or replicate. Hydroxychloroquine has been mentioned by the president and in the federal news about this, and I use question mark, we don't really know. And there's other antiviral medications, remdesivir, favipiravir. These are other antiviral intravenous medications that have been looked at on prior coronavirus infections that had happened before, also Ebola virus. So there's question mark whether these other viral medications are there. Convalescent plasma, what happens that after someone has had the infection, I mentioned antibodies, we look at to see whether or not after someone got the infection, can their antibodies that they now build up in their body, can they be taken out, and those antibodies, that's called convalescent serum or plasma, then be given to another person to halt their infection? Maybe, possibly, that's being looked at. What about dealing with the stress when someone's sick? What about communicating when they're ill and they're isolated? And what about planning ahead for future treatment? These are all things being done. And what about protection? And the first picture at the far right is really more comical, I believe, where someone was having a mask, they put plastic on top of their eyes, a bandana, there's various different types of equipment, and that picture down below, it says elevator A, and that person with the mask, that's actually me just recently, and I work in a hospital in the New Jersey area where I'm using a surgical mask, and underneath that is my N95. I took a selfie myself, and then behind me is a somewhat of a barren corridor leading all the way down to the ICU where COVID-19 patients are at my hospital. Am I provided the right type of equipment? Do I need a face shield? Do I need a gown? Am I keeping my distance away? And what about vaccines? When is the vaccinations all going to become available to all of us? These are things that we're all waiting for. to happen. We're all looking for that aspect of that. We all want that. But the vaccination is something that we're all going to have to wait for. And that's ultimately when the virus is still going to be around us in our world, in the United States, in our communities, that it might look like even with social distancing go away. But if it doesn't go away 100%, we're at risk of getting the virus again. What about the future and the recovery? And I use the term post-COVID-19 stress. How are we all going to feel? It's almost like a post-traumatic stress syndrome. Are we worried? Are we anxious as we try to open back our world? Transitioning also from people that have been sick and needing rehabilitation. When people are who've gotten the infection, it is not a easy or simple way to get right back to their body or get to their lives, because they could be in a weakened state. If they got it into their lungs, which is most of the situations, they could have long-term shortness of breath. They could have poor ability for capacity of exercise and moving around. So it's going to take some time. And getting back to our so-called normal, are we really going to be wearing masks for a lot longer? Are we going to keep our distance a lot longer? And what about if the virus then starts coming back? And the graph that I showed to the right shows different peaks of the virus. We hear a lot about flattening the curve and trying to reduce the number of cases jumping up high, reducing people going to the hospital, getting sick and dying. But there might be a second wave of the virus coming back in the fall. What happens then? And what have we actually learned? What all of us have learned, are we being protected? Was there enough protection for people in congregate living? Were we protected in having the right guidelines? Are we being looked at as a developmental system and really looking at people that have intellectual disabilities and dementia? And I say this in a rhetorical way, are we? And hopefully we're going to take heed on much of what we're doing now, because the COVID-19 today may be another virus or pandemic in the future. I wanted to show this as basically one of my last slides, is really say and talk a lot about the emotions. And I had gotten this through a friend that I had met through online, through social media, a whiteboard psychologist. And she was mainly using these drawings portray emotions that nurses and other people have: shock, betrayal, envy. And you can see it yourself of all the various emotions that all of us, I'm sure, have been going through from the very first thinking or knowledge about COVID-19, the first days and the weeks as it's come around us, as we might get sick or worrying about it. But we all like to think in all the information that we're all getting, we're all going to come together. We're all going to have the courage. We're all going to have hope for a better day. We all hope that, because we all want to look to the future and move on from there. So that is something that we all would like to believe we're all going to have for us in the future. So I wanted to thank you all very much for being on and having this conversation. Thank you very much. And as we move on to the next conversation, we are going to have our next colleagues and friends also review more information relevant to COVID-19. So thank you all very much.
Disabilities, and they had many patients who did poorly with COVID-19 but were discharged due to negative test results.
So let me explain briefly what false negative and false positive means, just to make sure everyone understands really briefly. What that means is that when you do a test, of course you want to know, does it really reflect the accuracy of what you're testing? And what a false negative means, that the person actually really has the disease or illness, but the test comes out negative and it's not saying it. A false positive is the opposite, where the test shows they actually have the test says that they do have it, but they really don't. So there isn't anything endemic within IDD where they're going to have it more or not. The challenge with coronavirus or COVID-19, the COVID virus or coronavirus is actually similar to a lot of other coronaviruses that are actually been around for millions of years, which can be a common cold virus. So there could be what's called a false positive, that they say they think they have it, but it could be that they already had a cold virus. a false negative, meaning that they actually are not showing it, has definitely been seen. It's really the issue about the quality of the tests that are done. The problem with the testing that's been done in the United States is that the FDA, which does a lot of the oversight and a lot of these tests, has limited in some of the value that sometimes they say about how good the test could be, because we're really desperate as a society to get the testing out. So the question really is, are we compromising ourselves? And that's a philosophical issue. Are we compromising ourselves by saying we need a treatment, we need a test, and therefore are we going to get a test that's like almost like the Plaquenil or hydroxychloroquine? We're so quick to get a test or treatment out there, and it's really not good, but people may not have done well. And that's the same thing with the test. But I think we're really going to have an evolution of the quality of these tests. That is really no great answer to with this question right now, but we want to ensure the accuracy of the tests have meaning behind it. We really do. So I don't have a great answer, but it's not good right now. So Rachel, next question.
Okay, so this is more of a broad question. What are your thoughts about states opening up for businesses?
Who asked that? Okay, who asked that question? Being funny. Okay, I'll just throw it out to Paul. Paul, in New York, and you're again putting your hat on here.
Yeah.
So what's your sense about your perspective if you were in, say, Georgia or New York or any other state might be doing that?
Well, the way I look at it, the question that we've posed to my team, because we're sort of coming into the second phase of managing this, is sort of what is reopening going to look like? And I think we're going to have testing. We're going to continue to do staff screening and contact tracing. I think screening and tracing are critical to managing this over the long term. I think we have to minimize cohorting. Unfortunately, even though we are a wonderful community, we love being together, we're going to have to really minimize it for a while. Minimize transitions for people as well. I think the aging population, those are difficult to begin with. I think we're going to have to minimize transitions, accessing the community differently, maybe a little less, maybe a little more intentional. We spend 4 hours driving around in a van to spend a half hour at some place. I think those are going to end. And continued enhanced hygiene, environmental cleaning, and good symptomatic screening. I really think it's all about a milieu of managing it, rather than just like a secret weapon, as you said earlier. That's our take on it.
And that's lessons learned. I mean, these are things that we're all learning, and we better pay attention. Otherwise, the virus is going to come back, and we're really going to get a lot of people sick, especially, like you said, Paul, especially if we're not having enough tests. So the key thing is really separation and hygiene and all that. Jadene, your perspective, any thought on that?
It scares me personally, and I like what Paul had to say, and I'm dealing with this. It's not really a small agency, but it feels small compared to what Paul's running. But I would love to see that kind of direction coming from the administrators of the agency that serve my son. Like really clear cut guidelines on this is what we're going to do and what'll be allowed, and so I'm worried about it.
Well, I think one of the things that we're really talking about is really, are we getting a consistent message from town to town, state to state, city to city? That's really some of the challenges that each of us almost like making up as we go along and sharing. But I hate to say it, I'm certainly not trying to be philosophical or political, is really need like a solidity of how we can do it all over. Because there's so much we're all the same, and we're all living in a similar situation with families and group homes, and it's all a similar variation of a theme. So why should there be so much differences? And I think the key thing for us in the unity in what we're doing as a society for IDD and disability is really reaching out with each other and sharing and learning best practices, both in the very beginning of social isolation, getting sick, hospital care, and prevention. And you mentioned, Paul, contact tracing, exactly right. So I think we're really basically learning from that. So Rachel, how are we doing on time?
So we still have 6 minutes left, so a bit more time for more questions.
Okay, great.
So another question is, are there any ideas you have heard to decrease the fear and stress of getting a nasal swab test in this population? It's an uncomfortable experience and is done by people in full PPE.
Well, I'll just, from a health professional, I know that if I'm the doctor or I'm the person doing it, I'm coming at them with a face shield, goggles, yellow, yellow gown. So here I am, not, and this is, and then I pull out this big stick, and then it's okay. I'm just saying that. Okay, I'll let Jadene and Paul take it from there. That's what I'm coming at you. So Paul, from an organizational standpoint, working with all these clients, what's your sense about how that can be approached, Paul?
Yeah, that's not fair. Basically, we would approach it as a social story. We would really work through a social story, try to desensitize folks, prepare them. In some cases, you may have to sedate an individual so that they can, be calm enough to get through the practice. Most of these sites, the testing will be done at one of those, drive-by or tents. It won't even be in an environment that's, to support somebody. So it's a scary proposition, but I would say a social story and maybe sedation.
I agree. I've had the swabs for flu, and I don't know if it's the same or worse. The swab for flu is bad enough, and I cannot imagine Matt going through that and tolerating it. And he tolerates almost everything medical. He's not a kid that we have issues with any kind of medical situation, but I can't imagine him. I think Paul's right. I think Matt would have to be sedated. So unless they can do the new test that's just at the front end of the nose.
But also we're familiar with papoose is also there, but also some of the testing that's going to be there is oral secretions and other ways. So there are other access to the COVID-19 virus aside from the nasal swab, this long, giant Q-tip that has to be shoved all the way up to the back of the nose. So I think that's something that we would have to appreciate is not only the quality of the test, the person themselves into their social or personal issues. So those would have to be taken into consideration about the choice of the test. Next question, Rachel.
So what more can be done to train DSPs and other support staff to further protect individuals receiving supports and minimize transmission?
I think this really goes to the question of appropriate protective equipment. So I'm going to put this to Paul as an organizational guy, and I work in the hospital. So you saw my funny picture there, but I'm in the hospital. So I'm, guy, I know that I got my face shield and all my N95. So Paul, what's your perspective nationally? I'll put your national hat on, of people around the country living in organizations, family situations who need to have protection. What's your sense about what can be done now or what we should do in the future?
In terms of PPE you're referring to?
Absolutely. Yeah, absolutely. Yes, absolutely.
Yeah, no, it's a difficult issue. I think collaboration is key. I think in order to manage your situation wherever you are, whatever state you're in, large, small agency, you need to collaborate with as many people as possible to find networks of supplies and just ideas, creativities, ingenuity. At Pathfinder, we keep everything simple. I did a video the second week, and I asked my staff to do 4 things, and then I put about 20 signs around the campus of those 4 things to remind them to do it. I asked them, wear your mask, wash your face, wash your hands, try not to touch your face, and when you go home, stay home. It was 4 simple mandates, and we rehearse it every week. And it's not insulting. It's actually very important. And I tell you, that's helped us remain COVID-free.
That's great. And I think that's a good practice, Paul, that you think about that, is that this is our so-called new normal, and learning these new normals and habits and behaviors is so essential. Jadene, what's your sense about?
I would just like to put a plug in, talking about this direct support professionals through NDSS, NTG, the National Association of Dual Diagnosis, and several others. We're doing 2 webinars next week. One of them is going to be on coping with just getting through a pandemic. And we're going to talk a bit about how we can support direct care staff who are caring for our loved ones and stuff. So that would be good. And the other thing is that the NADSP has a lot of good resources on their website for direct support staff for COVID-19. So I'll just put a plug in for them.
Yeah, good for Jadene, good for you. Seth, I got to make a comment on that. If surviving this pandemic does not get DSPs an occupation code with our federal government, I don't know what else we can do, because they deserve their own. We deserve an occupational code with a livable wage, with a respectable credential. And if we can't get it after this thing, I don't know what else we can do.
Well, the iron's hot, folks. I think the one thing that we're doing in advocacy, just like we're doing with these webinars, what we're doing for advocacy for hospital visitation rights, what the CARES Act did, and what you're talking about in terms of DSP support and recognition, this is really where, for we as advocates, are really working together. And I think right now, I say there's a somewhat of a silver lining with COVID-19. We're basically energized to really gain and work together to tackle these issues. So I think that is damn straight, man. That is damn right. Right. Rachel, back to you.
All right, unfortunately, it's time to wrap things up, but I'd like to thank Dr. Keller and Jadene and Paul for joining us today and presenting. So we will post this video on our website in addition to the questions that we didn't get to. And I would also like to thank the University of Pacific's Arthur A. Dugani School of Dentistry in San Francisco for making this webinar possible. Please join us again May 5th for our webinar on COVID-19 and people with IDD, the Special Olympics Response with Dr. Alicia Bazzano.
Thank you, Rachel. And I'm sorry, Rachel. And as Jadene was talking about, Jadene, how do people know about the Thursday, April 30th? And I heard there's another NDSS webinar as well.
There's one on the 27th that's going to deal with ethics and healthcare, and it's going to be very similar to this, question and answer primarily. And then the coping one with Lucy Ezralou and John Raphael and Dan Hermick, I think his name is, from NADSP.
That's right.
And I'd say if they can email you and you can send it to me, I can get information to them. I know NDSS has some stuff on their Facebook page, so they could find it that way.
Yeah, what we're going to do, Jadene, and I'll talk to Courtney and our AAD&D colleagues, is make sure that we're going to have the posting of this information for the one you mentioned on bioethical issues on the 27th, and this one coping during the pandemic, because these are going to be huge. We're all working together, folks. So this is information that we want to share with all of you. And certainly the feedback, the information is going to be very valuable for all of us. So I'll let you guys take it from here in terms of closing up our presentation.
Seth, if I could just add, just put a plug in for the virtual summit during the month of May through NDSS. There are a number of top-notch medical doctors who work with adults with Down syndrome. So if any of the student doctors on here are interested, they can go to the NDSS website and check that out.
Thank you, Jadene.
Sure.
And
all right, guys, what else?
Seth, if you just want to get in. All right.
Rachel, Alan, Steve, any closing thoughts? Courtney, who's got it? Yeah, Rachel.
That's all I've got. Just please join us May 5th for our third part of our webinar series.
Thank you, Rachel, for moderating. You did a great job. Can I just put on Courtney real quick? Courtney, I hate to be off script here. Courtney Frey. Hi, Courtney.
Hi. You are totally off script.
Is there anything you want to say?
I just wanted to thank everybody for tuning in. This was fantastic. Rachel, you did a great job. Seth, I'm so sorry we couldn't see you.
I didn't dress up for the occasion. My long hair.
Paul and Jen did a wonderful job. So this is fantastic. And we're going to keep information coming. We'll make sure those links get out about the other webinars that Jadene announced. And of course, we have our other one coming up May 5th, and we have some more that are in the planning stages right now. So I hope this is going to be, more information coming. Yeah, that's all.
Courtney, thank you. The information about our advocacy work obviously is so huge. The AD&D and is really taking such a leadership role in what we do, ventilation issues, hospital care and visitations. So how can people find that, Courtney?
Yeah, they can go right to our website, aadmd.org, and right there on the front page is an advocacy box. Just click it and you can start signing our petitions. And are we looking at your screen, Seth, or yeah?
How can I help?
I was just gonna say you can go ahead and click on our website and show them if you want.
I don't have it up.
Much to ask, that's okay. We
I'm not
probably
that,
need a
I'm not that
recipe.
I tried. I'm not that ready.
This is Alan. Last
Alan Wong.
comments here.
Yeah, Alan, Dr. Wong.
A lot of great questions. What we're going to do is we're going to have Seth and panel answer those questions and post those up for you on our website at a later time. We will post up the presentation, and thank you everyone for attending, and we look forward to seeing you on May 5th.
Thank you very much, everybody. Thank you for attending.
Nicely